Welcome to Grand Rounds, guys. Today we have Dr. Nina Mehta. She is a neurodevelopmental pediatrician at Arnold Palmer Hospital. She is board certified in pediatrics and neurodevelopmental disabilities. She earned her medical degree from United Medical and Dental Schools at London University, and she completed her residency in perinatal pediatrics at St. Thomas's Hospital. She then continued her training in Philadelphia, and she completed a pediatric residency there, and then she went on to Children's Hospital of Philadelphia to do her developmental and pediatric fellowship. She will be speaking to us today about the genetics of autism. Please join me in welcoming Dr. Nina Mehta.
Well, thank you very much. It's a pleasure to be here. And as you can see, today I'm going to talk about the genetics of autism. And I just saw Dr. Pollack walking into the room, so I'm glad that she's here. Oh, sorry. All right, good morning, everyone. It's a pleasure to be here, and as you can see today from the title, I'm going to be talking about the genetics of autism. And although there's not a cause known for autism, as we all know, I thought I'd talk a little bit about genetic testing, what we do for children that we see with autism, and what there is already known about autism in the genetics area. So before we move on to the genetics, just to familiarize everyone with the diagnosis of autism, it's a neurodevelopmental disorder, and it's got two main diagnostic criteria from the DSM-5, which includes persistent deficits in social communication and social interaction, and restricted and repetitive patterns of behavior, interest, or activities. And it's important to remember that it is a clinical diagnosis. There's no brain scan, EEG, or blood test that makes the diagnosis. So we do it purely from the diagnostic criteria, and it has to be impairing the functioning of the child or the symptoms to be considered a diagnosis and to be considered to be falling in the criteria. So as we all know, the prevalence of autism has been on the rise, and over the last 10, 20 years, it's gone up from 1 to 150 to 1 in 70. And it's really remained steady from around for the last 6 to 7 to 8 years at this area. And the thinking is that the increased prevalence partly is due to the increased the increased ease of diagnosis that we've had. We've been more aware of it, so the diagnoses have been made more often, and there have been greater efforts at identifying the disorder. And there's also an area where they've been thinking that the diagnosis has shifted from people being called cognitively impaired, or what in the past used to be called mental retardation, are now being called, are falling into the autistic spectrum. So we see the prevalence of autism in various conditions, and it can be quite high. The ones that are the two main ones that we talk about are Fragile X and also tuberous sclerosis. They're the two main ones in the genetic area that are having a high incidence of autism. But it's also seen in Downs, as you can see from here, and in other genetic conditions. So what are the risk factors? This is a long list. And some of the things are really questionable, but having a sibling with autism definitely increases the risk. Being male increases the risk, and then prematurity, low birth weight, and then some of those other things in there. There have been various studies that have shown that there may be an association with it, but obviously take it with a bit of a pinch of salt, some of those there. So what are the causes of autism? It's thought to be due to both genetics and environmental, as can be seen in this slide. The genetic factors can be either are inherited or de novo, and environmental factors are various, and still there has not been any definitive proof for any of the environmental factors. So today I'm going to talk about the genetics and then touch a little bit on the environmental factors and how they change the genetics of autism. And if I have time, then I have some slides on the counseling and management of autistic spectrum. So there have been multiple lines of epidemiologic evidence that support the strong role of genetics in the etiology of autistic spectrum disorder. Starting from back in 1977, which is when the two British physicians actually, Susan Falstein and Michael Rutter in the UK conducted the first study on twins, studying 21 same-sex twins, and at least one had a diagnosis of autism or the features of autism, and they found that there was a lot of heritability, and in fact it's gone on to show that identical twins share about 60 to 90% of autistic traits when the fraternal twins only shared 0 to 10%. So that tells you that there's something going on in the genes. Sibling recurrence is high as almost 20%, another reason why we think that it's inherited. The occurrence of autism spectrum with single gene disorders, like I mentioned, tuberous sclerosis being the big one, and Fragile X also is inherited. And there hasn't been any single risk factor that explains the changes of increased prevalence over time. So that's why they think that it may be genetic. Now, just when touching, this is just a little thing I threw in there about the increase of autism spectrum thought to be present. It is known to be higher in males and females, and almost up to 4 to 5 times higher in males. And this is one hypothesis, that the exposure of high levels of secreted testosterone during early gestation results in cognitive hypermasculinization of the brain, and this triggers the onset of autistic spectrum disorder. So with that, the recurrence risk in siblings of a child with autism is anywhere between 3 and 10%. But it's higher if the child is female rather than male. So it's 7% if the affected child with autism is female and 4% if the child is male. And then if you have more than one child, or like multiple children with autism, then it shoots up to almost 50% in a future pregnancy. So if the mother's already had 2 kids with autism, then the third child is going to have a much higher risk. And that's really most likely then you would be really searching for a genetic background. So what is the reason why genetics is so important in autism? What does it bring to us? So one of the things is that if you understand the molecular and cellular mechanisms, it will help us to find a better way to intervene and find treatment that would be appropriate for the different features that we see in autism, but also maybe even in the future be able to find a cure. But it's still in its infancy, and the main ways that we're going to be able to find a cure is if we know ways to connect the genetic findings with the behaviors, and then it would be able to help us find the cure and also appropriate treatment. And if we do that, then we can apply it to the different subgroups. Now, ASD is a spectrum, as we all know, and it has a lot of variation in this spectrum. But there are certain groups that there are milder ones or there are higher functioning ones, and then there are ones that are more significantly impaired. So it would be very important to see what is the background in these kids, which are the ones that are making the kids less affected in their behaviors or more affected. This is just a little slide I threw in there to just show how the genetics is going to affect the outcome. So at one end, and he said that there's, to be able to do this, I have to move that here. Maybe not. I'm not sure how this is going to work, and I just lost my mic. Sorry.
You can use the mouse. The mouse has an arrow. You can go into it.
Sorry?
You can use the mouse. The mouse will have an arrow. It will show you.
Ah, okay. That comes up on the screen. Okay. Can you also hear me? Okay. All right. So on this side we have the genes, and then it's we have the genes going to the synapses and then into the circuits, and then this is where we have the behaviors. So it's sort of just showing you going from the genes, how the specific genes are going to affect the neurochemicals in the synapses, which then go on to affect the circuits in the brain, and then that's what's affecting the social impairment and the restricted and repetitive patterns of interest. But why has it been so hard to find an answer? And the thinking is that individuals are all 99% identical genetically, and the ASD research is interested in that 1% difference, and that's how we're going to really find the cause. But it's been difficult because it's a really highly heterogeneous disorder, and until recently we haven't had the ability to search the chromosome in such detail to find the specific areas of deletions or duplications or any abnormalities in the chromosome. And the reason is that it's not due to a single gene. There are many different areas that will have deficits that can lead to the cause of autism. So what are the genetic testings that we do? Well, first talking about the genetic testings and the success rate that we have in finding an underlying cause when we do the testing, because it is recommended to test all kids with autism for genetics abnormality. But the rate of success in identifying a specific diagnosis in a person with ASD is around 6 to 15%. But with the newer testing, it has gone up to around 30 to 40%. And that has yielded a bigger diagnostic yield. So genetic testing, starting off in the 1990s with the FISH testing, the fluorescent in situ hybridization, became generally available for use, but that can only find a single loci, and the most common ones are those listed there at the bottom. And with this testing, you have to know what you're looking for to be able to find out whether it's present in the child. And it's looking for the presence or absence of specific DNA sequences on the chromosome. So common conditions that are found through FISH testing are like the Prader-Willi syndrome, Angelman syndrome, and the vitrecardiofacial syndrome. And as I said before, it's a single gene disorder that we're finding, and in here you can see that it's a single change that you'll see to make that diagnosis. These disorders, the single gene disorders, account for like 5 to 10% of the cases with autism spectrum disorder. And here we just have a few more there. Tuberous sclerosis will come under there, Fragile X, Angelman's, as I mentioned before, the vitrecardiofacial, as I mentioned before, and also Rett syndrome. Then in the 2000s, we got a more specific comprehensive testing for the chromosomal microarray. And with this, it's what increased the yield up to 30%. It's increased higher if we have findings in the autistic child, and those findings are things like microcephaly, seizure disorders, dysmorphic features, and then you're going to find a much higher chance of seeing a genetic abnormality. Also, if you have any individuals that have a family history, and that doesn't have to be specifically just a family history of autism, but if the family history has any other developmental disabilities or even psychiatric problems, it's been shown that it proves more yield in these tests when you carry them out. So chromosomal microarrays are technology used to determine if there are small, extra, or missing, so it's either duplication or deletion of genetic information. And these gains and losses are what they call the copy number variants, or CNVs. And they can be of no medical consequence, or they can actually be the cause of what the condition is that you're looking at. So this is just a slide showing how that's done. and just get a small sample, and actually the specific details I'm not going to go into it. I'm not a geneticist. We have a geneticist sitting here who may be able to say more if anybody has any questions, but you take a small blood sample and you have a reference DNA and a test DNA from the patient, and you put it through the testing, and it comes out to show you whether there's any areas of loss or gains. And these copy number variants is what will be reported in your reports when you get it back, saying that you have the areas of deletions or duplications. This is how much you have of a gain or a loss of this many amounts in what area of the chromosome, and then that's what you're looking at. And the importance, and we do this testing on all autistic patients, as I told you. And when we get a result, I usually refer to genetics if there's something abnormal, because it doesn't really, we're not at the stage where we know that if you have this deletion or this duplication, this is what the outcome is going to be. And it's more in future and with more research that they may be able to group together certain patients that have this specific deletion here, and this is the kind of autism spectrum and behaviors they're going to have. And that's where we're getting to, or hoping to get to. So we find the copy number variance in about 10 to 20% of children with ASD, compared to only 1 to 2% in unaffected siblings. And it's also found in children with just regular developmental disabilities or intellectual impairment, so it's not specific to autism. But it's the one that's most likely, the genes that are being altered, as I mentioned earlier, is at the synaptic level of functioning, where the neurotransmission is actually occurring. So here are some of the copy number variants that we found, and they call them the autism syndromes because it's not really specific diagnosis that this is a syndrome here, but they are associated with the findings of abnormality. The kids have autism, and then they have certain other things that go with that syndrome, and then that's what we're seeing as an outcome for autism. The most common area that they found with this is in the 15q region, and that's the Prader-Willi or Angelman syndrome. But other areas are also of importance. So moving on from the microarray, then getting even more specific is looking at candidate genes. And candidate genes are any gene that's thought is likely to cause a disease because it's located in a particular chromosomal region suspected of being involved in the disease, or its protein product may suggest that it could be the disease gene in question. So we're really looking now really at the specificities. And the identifying the potential autism-causing candidate genes is where we're going to find the answer, because that's really finding the specific area that's affecting the brain development at the synapses level and with neurotransmission. So here are some examples, and these are just names. I mean, I actually haven't even looked and see what exactly WNT stands for, but the WNT2 gene is involved with neuronal proliferation. The RELN genes are involved in neuronal connectivity during brain development. And then there's the HTR2A receptor transporter gene, which have also been identified, and the serotonin transporter gene have also been identified to be candidate genes in autism spectrum disorder. So what is the contribution of these genes? And this is in a little bit more specificity. So we're looking at cerebellum development. They found a specific candidate gene that may be involved in that. Brain cell migration, differentiation and synapse formation, stress response, social skills, neural migration in the developing brain, and serotonin transport. And all of these areas of deficits in the brain are the ones that have been thought to be are partly thought to be responsible in the features that we see in autism, with the lack of social response and social interactivity that occurs which is the biggest deficit in children with autism spectrum disorder. And then these are the main ones that have been found in the synaptic genes are the NLGN3, NLGN4X, and the SHANK3. So you might hear about these being involved. And it's all still in the research basis. I mean, there's nothing that we don't actually even send off to test specifically for these. Maybe genetics, when they see a child, they may be doing that, I'm not sure. But when we send it off, we send off for a specific, just for a generalized chromosomal microarray, and I'll talk about the test that we do in a little bit. But moving on from the genes to the environmental factors and how that affects the genetic outcome, and that's where we come on to epigenetics. So environmental factors have been shown to affect, or have been shown to be a cause of, possibly involved in the cause of autism. The gestation exposure to high levels of pollutants, there's been studies showing that may be a cause for autism in the newborn baby. Complications in pregnancy like viral infections or maternal stress. And they even talk about the artificial insemination and ovulation-inducing drugs, which I think are probably used more commonly now as women are having children later on in life and then maybe having problems, they're going to go on to use those medications, and whether that is causing an increased risk in autism. And that's just showing it in a little bit more graphic form. The genetic predisposition, the environmental factors, and then going on to, so here we have the genetic predisposition, then the environmental factors, both together going on to affect the synapses, which then affects the connectivities of the neurons and then goes on to alter the behavior, cognition, and emotion of the patient or the child. So as I was mentioning, the epigenetics is where this environmental thing is thought to have its effect on the genetic makeup of the child. And this changes the expression of the gene. It's not actually changing the DNA or the content or material of the person. And it's thought to be going through the histone methylation. And it's different in persons with ASD on genes regulating neural connectivity, social behaviors, and cognition. And the epigenetic changes from methylation related to environmental exposure might increase the risk of autism spectrum disorder. And here's another graphic presentation of that. So if you unwind the chromosome to show you going on into the DNA, and then the DNA have these histones, which are the proteins around which the DNA is wound up. And when we have the environmental factors over here affecting it, that's the area where it's modifying the histone, and then it goes on to change the outcome. So there have been, as we know, there are several genetic syndromes that are comorbid with autism spectrum disorder, and they show dysregulation of these epigenetic markers that help regulate the gene expression. And so that's where the environment is becoming affected into the genetic chromosome, into the genetic makeup. And this is, I think, where the most promise is going to be in finding a model to understand the increased incidence that's suggested by epidemiological findings. So what testing do we do? The AAP guidelines suggest that testing should be made available to all patients, and sometimes the mother will say that she doesn't want to do the testing because she doesn't really want to find out or need to know, and then it's really up to them. Obviously, we tell them that we don't have a cure for it. Once we have the finding, it's not like we can change anything in the child, but it is important to know, particularly if they're going to be going on to have more children. So the two main ones that we do are the Fragile X testing, and in males, and the I even do it in the females, and the chromosomal microarray, which is looking at the deletions, duplications, and the copy number variant. And with this, shows you what the yields are. So the microarray is around 10%, Fragile X 1 to 5%, and then you have the other ones that are showing less of a yield. So moving on to the genetics of autism, the role of a clinical geneticist is to determine the etiology of autism spectrum when possible, to improve care and management, and to provide genetic counseling. So from here I want to move on to a little bit about the counseling and then move on to management of autism. So with genetic counseling, for those without an identifiable etiology, counseling should be provided using the recurrence risk data, as I've mentioned earlier. But those who do have an etiology is obviously provided through the geneticist for follow-up, and then recurrence risk depending on what the specific etiology is, like if they've been found to have Fragile X or if they've been found to have tuberous sclerosis. So with genetic counseling, the copy number variants, which we were talking about earlier, they do show a marked intra and inter-familial variability in their clinical manifestation. So then, as I was saying, that it's important to do the studies in the parents, because even if they don't have any obvious abnormality, they can have an abnormality in their genetic makeup. And identical variant that's seen in the child will be found in the parent, but will be causing a different condition, such as ADHD, intellectual disability, or any psychiatric problems, and even seizures. So it's important to get the testing done. So this was interesting. This is the parental perceived causes. So what are the most common beliefs that the parents have as to the cause for their autism? And the highest one that they think actually is that it's genetic influence, 73%, although only 10% had actually seen a genetic doctor. Then 23% think it's because of the pregnancy and delivery. 20% were thinking that it's childhood illness. 27% vaccines. Diet is less, environmental exposure is less, and the age at birth are fewer. Parents think that is the cause for the autism in their child. So the biggest one they also think is a genetics thing. These are just some research centers that are doing the studies in the genetics, and where they're doing more studies to find out the more specific details. So from here we can move on to management of autism spectrum disorder. I don't know what we're doing for time, but the interventions that are best supported by evidence and are examples of good practice have four main principles. There's individualization, structure, that's adapting the environment to maximize their participation in the behavioral therapy, intensity and generalization, and family participation. And before I even talk about this, I should have told that the most important management for autism spectrum disorder, actually the only management really, is behavioral therapy. There isn't any other, there may be many things out there that you read on the internet, but the one that's shown to be the most effective is behavioral therapy. And then it's divided into those four areas, which is where we're going to see the maximum improvement. So the three main programs which have this behavioral therapy are the applied behavior analysis, which most of you will have heard about. Then there's also the DIR, which is the developmental individual difference relationship base, which you may not have heard about, but it's in short called floor time. And that was also actually founded by Stanley Greenspan, who's now passed away. But his idea was that if you actually just get on the floor with the child, making eye contact and doing behavioral therapy constantly with the child face-to-face, getting those circles of communication going, that in itself is going to improve the behaviors of the child with autism. And then the final one is actually used out in Mooring on the West Coast. It's called the Education of ASD and Related Communication for Handicapped Children, the TEACH mechanism, and that also you may hear about for autism, and that's also uses the visual cues, schedules, work systems in behavioral therapy to make what you expect the child to be able to do and address those behaviors through the therapy, through the behavioral therapy. ABA, which is the most important one, which is the one that's most commonly used, is through Lovaas, who was back in the 1960s when it was first mentioned, and it still to this day has been shown to be the most effective, and that's really specifically analyzing the behaviors in the child and then addressing those specific behaviors. So they'll do multiple charts, seeing what sets off the behaviors, and then what are the things that they can do to help to improve on those behaviors and diminish the unwanted behaviors. So if there are 3 words that summarize what should be done for people with ASD, it's personalize the behavioral therapy, contextualize it, and empower the families. And empowering the families, I think, is the most important thing, because when they get this diagnosis of autism, obviously, nowadays if you tell a family that your child has autism, it's not like they ask you, what is that? They already know. They know everything about it, actually. They've read about it. They know. They're already coming in thinking that my child has autism. So when you tell them the diagnosis and they tell the patient that the child has autism, that's when it really hits them that, oh, that this is the diagnosis that my child has. And then they're obviously going to be mourning the loss of their perfect child. That's the second challenge. The first is obviously making the diagnosis, because there's so few of people in this field around who are making the diagnosis. It's not easy to get the appointments. And then they'll go through their 5 stages of grief, denial, anger, bargaining, depression, and then finally acceptance when they arrive to a new norm. And then they understand that this is the child they're going to have and be with, and then they can move on to work on how are they going to help the child. So that's how you're really working with the family. So regardless of their age, most people with autism spectrum around the world live with their families. The higher functioning autistic spectrum children and the ones that used to be called Asperger's, now we call them higher functioning, they often are living independently. And they can go on and have a successful career. They even can get married and hold a good, successful job because of their higher functioning abilities. And I feel that if those children that we see early on, if you really do help them with their socialization skills, their communication, then they become really successful as adults, because even then there's nothing that's really stopping them. I always tell them there's nothing stopping you from achieving whatever you want to achieve, because your intellect is there and you can go on. And I have kids that have gone on to college and they're at UCF or University of Florida even, and doing well. And they need some support every now and then, because obviously some things, when it's not going their way, is going to be a problem. And I don't know if you hear people have watched The Good Doctor on TV, which has recently come out, but it's a surgical resident that they're portraying who's high-functioning ASD and successfully completing his residency. I mean, this is a show, it's not real, but it can be possible that you could go on, I think, to do that, because it is possible to have that. But the ones that are not so successful are living with their families, and they are the ones that need the support, and we need to know what their priorities are, what their dreams are, and what they would like as their outcome. Because often, once the child reaches 21, they move on from here, from our care, and then they really don't have anything else to do or anywhere else to go. So it's really important to tell the families and give them hope that what things this child is going to be capable of achieving. Having access to a support network and receiving support related to their child has the greatest benefit for parents of children with autism. And that's important to know, that really it is support, and a lot of support. And that support can be provided from all directions, but it's not always easy to get. And often the parents are looking in not the wrong places, but once they get the diagnosis and they start searching and they find out all these things that might help to cure it, and then they'll go down that path, and you're really wanting to try to make sure that the parent knows what's important and what's important to get as support for the child, rather than trying to find out what the cause of the autism is or what the or what's going to cure it, because it's important to say that really we haven't yet found a cure for autism. And the families are the main interveners in the help for the children. They are going to be the first people there, obviously. So they need the most training. So parent training, and that includes the siblings. And I actually, whenever I have a sibling that comes in the office with the autistic child, I always talk to the sibling and always say, you're going to be this child's biggest therapist. And even if the sibling, if it's a normally developing sibling and it's younger than the child, they are going to be such help to this child with autism, because it's just the connection that they need. And if the child that's the normal child doesn't know how to connect with the autistic child, then there's not going to be the relationship bond. But if you show the child that you can also connect with your brother or sister, and help them to understand that they actually are going to be helpful for the child, then they actually become better bonded and better interactive and actually do so much better. And it's amazing how autistic children will be so much better with their siblings than they will be with therapists, with an adult therapist. They can do so much more therapy for them. And when we talk about ABA therapy is really shown to be effective if it's given 40 hours a week. And that means 8 hours a day, or at least that much. Or mostly all of the waking hours of the child needs to be sort of doing ABA therapy. And you can't get a therapist who's going to be there the whole time. So the parents and the siblings are the ones who will continue the same therapy at home. And then there are new technologies to train families on the internet. There are many programs that are now available, and most kids will have iPads, and you have a lot of things on the iPad that help you with your social communication and interaction, making eye contact. There's so many different programs. You're going to help the family manage the family stress, and helping them make the right choice when they're looking into all this alternative and complementary therapies that are out there. You really want to make sure that they are in the right direction to get the things that have some empirical validation, such as we know speech, behavioral, OT, and PT all have been shown to be effective. And then going into a proper special education program. And then at the bottom is the pharmacological interventions, because medication management is used only for the symptoms of autism, which are, if they're significant. And those symptoms I'm talking about are like if you have a child who has a lot of self-injury or aggression, that's when I'll use medication management. And if the child has behaviors of ADHD, and they do, most of the children have increased hyperactivity, inattention, and as part of the condition, even if you don't get a different diagnosis of ADHD, just having autism, they do innately have those behaviors, and sometimes they are impairing their functioning, and then we will use medication management for that too. Most often I use the non-stimulants rather than the stimulants, because the stimulants often are making the behaviors worse. They sometimes make them more introverted, or they might make them more aggressive and irritable. So just a little bit to end with, without a specific diagnostic test for autism, the diagnosis can sometimes be delayed because it's a subjective diagnosis. One physician may say yes or say no, and so then they'll have to go to another physician or a third physician, and sometimes the diagnosis is delayed for autism. So I just have two sites on there where parents can get more information about autism. And then to end with, here are some organizations that we commonly give out to most of the parents that come in. And they have a lot of information on there too. So I think that's it. Any questions? Yes.
To comment, two things about the genetic testing.
Yes.
One, we usually do karyotype unless we think someone has Down syndrome, Klinefelter's, Turner. That's true for anything. Pretty much doing MICROARRAY for most cases.
Yes.
And the copy number variant, we have to be careful with that. It's not uncommon. The one of the parents who is functional, no report health issues, has the same variant. So that's part of the whole multifactorial aspect of these copy number
Copy
variants.
number, right.
We feel like we do offer testing to the parents.
Yes.
Sometimes they choose, sometimes they don't. The problem is, if you find the same variant in a functioning parent, and the variant in an autistic kid, you're like, well, okay, what's going on here?
Right.
What does that mean for the parent for future children?
Right.
So it's something we do offer parents, but they may or may not choose to accept it. And that's
But does that? But when they have that finding, then are we are being more aware that the affected, there's another child they have would have the same condition or
well, that's
not?
always a possibility. But the thing is,
More
also
likely,
the parent, well, possibly what the parent has the change and doesn't have the condition. But you're right. We have, it is certainly always going to be a risk, and we never tell families
Right.
that one child with autism always means there's increased risk for second child to have it. But even if one parent has the same variant, I'm not sure we can say that risk. I'm not sure we can say that risk changes the risk significantly based on that.
I just want to add on to that. When you have a newborn and you get a microarray,
Right.
and there are the autism susceptibility genes,
Right.
please do not tell the parents that their child is susceptible to autism. There are about
Okay.
100 genes, and most of them do not evolve.
And they don't evolve to give the
Yeah,
condition,
but the
right?
parents go home thinking, oh my God, I've got to watch for autism. And in fact, your child has something totally different. So it's a delicate balance. We're not
Right.
there yet where there's a cause and effect.
Right.
It's a susceptibility gene. But having a newborn who's 2 days old and
Has found this. In
yes, it's so I really caution, and it's not going to change the care of the child. It doesn't change our observation here. So I really caution the residents about telling the parent, well, you have this gene, so you might get autism. Really be careful about
Yeah,
it.
that's true.
It's been an issue since they've identified, there are about 100 genes that they've identified.
Right.
And it's an issue for us, and what do you do with that?
Right. So, what percentage do go on
Go on?
to get autism? Because I was just thinking that if they have the autism susceptibility gene, then in my mind I was feeling that they actually should be on more alert.
I think that if you have a child who's going to be watched anyhow by their pediatrician,
Right.
to make the parent neurotic.
Yeah, that's
worse
true.
than-
So don't even tell them you're saying. Okay.
I think there's
Yeah.
so many factors that enter into it. Is the child completely normal otherwise?
No, absolutely. I mean, I think it's the same true when you have a sibling of a child with autism. And once the parent has one child with autism, they are, and we tell them that because of this increased risk, then they are going to be much more vigilant of the second child. And often you're right that you'll see a lot of things that they'll say, oh, is this child, is this abnormal, is this abnormal? It is a little bit more worrying for the parent. But then we are seeing the siblings having more chance of having autism. So you don't want that to be missed either.
No, you don't want it to be this, but I think that it doesn't change your care for
It
the
doesn't
child.
change your care, no.
You're going to treat them no matter what
Correct.
the testing shows.
Correct.
I think,
Right.
I would say there's also one reason to possibly test parents when we do have a baby newborn with a chromosome microabnormality of question.
Right.
Again, when the healthy parents has a change, you can say, well, you're healthy, you have the change. We'll keep an eye on the child. That's
Yes.
something reassuring that you have it and you're doing well.
Yes.
So that
Yeah,
can be
that's
reassuring in
that's
that
true
context.
too. That's true too. So yes.
Regarding on what you just said, if you have a child with this genetic predisposition, you can use that in order to have the parents aware that if the child has a speech delay or poor communication, to do an early intervention instead of waiting?
You're going to get the intervention.
They-
If you have a child with a speech delay,
They're going to get it anyway.
you're going to get the intervention no matter what.
Yes.
That's not always the case.
But think about it as a parent. If you have someone who has, if you know your child, your little newborn, has an autism susceptibility gene, every single thing that they do or don't do is going to make them neurotic. It's a balance, and I don't think there's a right answer to that.
So how often do you do that? The autism in the newborn. How often does that happen anyway?
Well, when we get a microarray and we find an autism susceptibility gene, we're doing the microarray not for autism.
No, I know. What are you doing when you're doing microwave for?
22q.
Oh, okay, I see. Oh, and then they'll find the autism susceptible gene in that. Got it. Okay.
A coincidental finding of it.
And it's an incidental finding.
Yeah, I just-
Yes, in that case, I think it's probably not
It's not.
good to tell the parent.
No, and I just want to say, I mean, of course, making the differentiation between the two diseases, we scare a bunch of parents with the fear genetic testing. Because when they come positive with one genetic abnormality, we have to bring that kid to the hospital. We have to test for cystic fibrosis to make sure that those kids are either carriers or they have the disease.
You talk about the newborn
And
screen?
when you do newborn screening, absolutely. If you have a positive IRT and a positive one genetic abnormality, you have to call these parents and tell them that potentially they have a disease that is life-limiting.
But you get that is black and white. You get an answer.
Not
Yes or
always,
no?
but
Yeah.
probably 90% of the time it's black and white. But there is a subgroup of patients that they always are kind of up in the air. I mean, you tell them they have the disease or you are a carrier. But I mean, but the parents know, and statistically, you know, the fear, what you just said, is that over time, these parents are more confident knowing what the outcome is than not.
I don't think they're.
No, they're not probably comparable, but you know, you have a condition that it can be life-threatening. You tell the parents are scared for a period of time, but they figure out what's going on. And if I have a child that potentially can have autism, and I know and I'm aware of what I need to look for, and I can do an early intervention, which doesn't always happen.
Yeah, and that is, I think that's
we see kids
true.
that they are misdiagnosed
Yeah.
or
It's not
diagnosed
like,
very late.
they get a copy of a report, and on the report it says autism susceptibility gene. I'm not withholding that from them.
Well, you just said not to
No,
talk
no,
about
but
it.
I would not make it an issue that I focus on. It's, don't focus on it, exactly.
Oh yeah, no, but I think the parents should know. I mean, I understand that we need to develop our skills not to scare them.
We're not keeping it from them.
Yeah.
They get a copy,
Oh, okay.
absolutely.
Yeah,
Oh,
yeah.
I misunderstood. I thought
Right.
you said not to tell them.
Right.
No, not to.
Yeah, that's what I actually thought. But you know, I think that it is important to know. You're right, because they do a lot of running around. And I have children that haven't gone to speech therapy and they're 3, or even older, and they haven't yet been referred because they've just been running around trying to get somebody to send them for it. So he's right in saying that if there is an awareness that, okay, this may be a problem, we've got to act on it earlier, then it might help them to get their pediatrician or whoever refer them earlier because, okay, this is more likely to happen.
We follow those children so that we pick them up early.
So you pick them up early,
Like
okay.
others, there's a known speech delay. We
Yes.
follow them much more closely
Yes.
because, in fact, if they have speech, and we'll tell the parent, you know, we have to be aware of the possibility of speech delay. So we have to
Right.
be attention. I'm certainly for that.
Yes, and it's the same with the sibling. You follow the sibling more closely if there's a parent. If there's one child that has autism, then you're keeping a little bit more of an eye on the child, on their sibling, because there's an increased risk. And if there's 2, then definitely the 3rd one you're going to keep an even closer eye, because it's more likely. Yeah.
So for kids who have high functioning autism,
Mhm.
are their genetics different than, I mean, obviously if you have a true syndrome, then they often have delays or
Right.
But is there anything specific about high functioning autism and the genetics that you know?
I don't think there is.
Very unlikely.
Well, in terms of what you see, right? You have genetics.
No, it hasn't.
Genetic syndrome is not going to have, they're not going to have.
Is it more just a function of like their intellectual potential? They still have the same disease with intellectual potential, or do you think it's a difference in the genetics of that autism, of that form of autism?
Anybody knows? It's a whole spectrum idea. I mean,
And also, what I find fascinating, these families, you get a history, this child has autism, but his sister has anxiety, and uncle over here, he's a little quirky, talk a little bit later, he's doing okay, he's a computer engineer. You get this history, and that kind of goes back to multifactorial.
Multifactorial, right.
There's a lot of that overlap, a lot of anxiety, a lot of OCD, and the other
All
family
of that
members.
comes together into, yeah.
They spoke of that epigenetic stuff.
Yeah, yeah.
Maybe a different expression. Not quite as intense.
Exactly. With environmental affecting it, right.
Well, environment affects pregnancy differently.
Yeah.
I'd like to